Yes, so next up, we come back across the channel, across the Irish Sea, to Dr. Brian Sweeney, the consultant neurologist at University College of Cork. Many of you are probably patients of Dr. Sweeney's, and he's going to talk about MS treatments, both current and emerging. And don't forget, hashtag MSLiving.
Studies in MS3. That's the top one. Is the one at the top, yeah. Thank you very much. Usually there's a warm-up act and before the main speaker, whereas I think today, obviously our guest speaker spoke first, and I'm sort of the follow-on, or as Woody Allen said, you never send one comedian on after another. So I just want to sort of thank Dr. Prof. Giovannoni and for his talk, and I might try to respond from an Irish perspective towards some of the things he said in his talk, which I think are very interesting and probably quite provocative in terms of the practice of neurologists, for example. So we know that I want to make a few points in the first few slides. So we know that this illness is episodes disseminated in time and space. So usually when MS develops, it's a chronic illness which tends to relapse and remit over time, or sometimes in people it can be more slowly getting worse over time. It's an autoimmune illness, so your immune system is attacking the nervous system, at least in part, maybe not all of it, but that's a big explanation of it. And that this causes inflammation and demyelination and axonal injury, as Prof. Giovannoni has so graphically illustrated. We know that the typical onset is between 20 and 40. The average age is between 28 and 31. And we know that up to 9,000 people in Ireland have MS. And from the studies of Michael Hutchinson, we know that it's about 1 in 500 in Donegal and I think 1 in 700 in Wexford, something like that. So generally around that level. And just to mention that there can be a genetic element in that MS is more common in first-degree relatives of those who have MS. So if you think the general risk in the population is about 1 in 700, there's about a 3 in 100 chance that somebody else in the family will be affected by MS. So it's not like 50% or anything, but certainly there is an increased risk. And we do have families where maybe 2 or 3 or even 4 people are affected. And of course that has a big impact on that person's experience of MS and what they might expect in the future, or what their thoughts are about the illness based on their own family experience, which is a little bit greater than that of the community. Having said that, I think that in Ireland, where we have a fairly closely connected community, people's images of MS are often based on experience of friends or family or neighbours or other people in the area, although perhaps that's less so now than it would have been in the past. Gavin mentioned about measurement, so very important aspect of what we do. So how can we know that a treatment is effective? How do we know that this treatment is working for me? If I'm taking these drugs, which do have quite serious potential side effects, how do I know that is it worth it? Is it valuable? As he mentioned, there are various rating scales that are used. The most popular one is called the Expanded Disability Status Scale, the EDSS, which is a 20-point scale ranging from 0 to 10.0. It's 0, 0.5, 1, 1.5. And it was developed by a guy called John Kurtzky, so it's sometimes referred to as the Kurtzky scale. And it's a scale of severity. And it would be used as a measurement in clinical trials, so that if you progressed by 1 point on the Kurtzky scale, that might be seen as a significant progression, which would have been the aim of the drug to try to prevent. There are other techniques for measurement as well. For example, there's a thing called the MS functional composite, which looks at things like memory, upper limb function, and so on in a kind of a more timed way, and that can also be used as an outcome measure in clinical trials. In terms of the other measure we have, obviously when you're looking at outcomes as well, you can look at what I'm mentioning with rating scales is measuring ongoing disability. You can also count the number of relapses that people have, so relapse rate is another measure that's used. And then the other big measurement we have in routine practice is MRI, as Gavin has already said. So you can look at the number of lesions present and do comparisons from one scan to another. You can look at a thing called contrast enhancement, where an injection is given into the arm, and if there's a lesion that's active in the brain, that will light up on the scan. I'll show you some examples of that later. And you can also look at measurements of what are called brain volume. And that kind of relates to what Gavin was saying about the fact that these areas called the ventricles, for example, they get bigger as the brain around it gets smaller. And so by measuring these degree of atrophy, if you like, of the brain, that might help us to gauge the response to treatment. And in a lot of clinical trials now, as well as getting the number of lesions on the scan and the measurements of what happens and gadolinium enhancement and so on, you will also see measurements of overall brain volume, and that would be used as a way, and some drugs would claim that they would slow down the rate of change in the brain to that of the normal population. He has mentioned what are called biomarkers, which are other tests that we could do in the blood or perhaps in the cerebrospinal fluid, that if we were to check them, that might give us a gauge of how well the person is doing, what their prognosis might be, or how well they're responding to treatment. So this is still fairly early. They're not really commercially available as a routine, and you'd have to get into the area then about how would people feel about having regular lumbar punctures, for example, if that was the method chosen for doing that measurement. So at the moment, the main measures we have are these rating scales and the MRI. Now, when I started, as I'm getting to my older part of my career, there were 11 neurologists in the Republic of Ireland. So there were 3 in Munster and there were 8 in the rest of the country. So that was for a population of 1.2 million people when I started. So in that case, there was no question of measurement or having lots of time or anything like that. It was just see and sort, try to get through as many people as you possibly could. It wasn't pretty. And now the numbers have come up. There are about 40 neurologists in Ireland, so we're approaching nearly 1 per 100,000. And there's a hopeful plan that in the medium term we might go up to as high as 60 or 70. But when I started, it was quite possible that many people in the country had never even seen a neurologist, let alone been offered disease-modifying treatment. I suppose it's a reasonable question to ask through the group here today and to the MS Society. Can we take it for granted, for example, that everyone in Ireland who has MS has actually seen a neurologist at some stage in their career? I think that's much more likely now than it was. But I would certainly agree that what that meant was that because the rating scales were quite time-consuming, it probably meant that it wasn't that easy to do that in routine clinical practice, given the workload that was there. Now, on the other hand, we have another issue which is very important for all people who are dealing with illness and chronic illness, is the idea of measurement and regulation. So how do we know that as a society that we're getting value for money for a treatment? Obviously, if you're living this illness as a person or a family member or a friend or relative, that's the most important thing to you. You can't measure that. The impact that this has in someone's life could be huge and can be unquantifiable, and it's actually almost sinful to try to measure it in financial terms. But when the money is tight, you do have to be sure that whatever spend you're getting is appropriate, and that the value of the treatment is worthwhile. So let's say, being very controversial, if a treatment, let's say we had a patient with cancer, if they got a particular drug that cost €100,000, but it only prolonged survival by 4 weeks, would that be value for money as far as society was concerned? That 4 weeks might be invaluable to that family and to the person involved, but for society, can we afford to pay €100,000 for that intervention? So that's a very dark area. It's not a very pretty area, again, but it has to be done as part of the routine. And there is a centre in Ireland called the National Centre for Pharmacoeconomics. In some ways, what Gavin is saying, and it's interesting because we tend to look to the UK, perhaps in Ireland because of our colonial past, as being the avatar, but it turns out that in a recent survey, the UK scored second from bottom in surveys of MS treatment compared to the rest of Europe. So, and they have a thing called the National Institute for Clinical Excellence, which is similar to our National Centre for Pharmacoeconomics, and they basically dictate to the UK population whether or not a treatment will become available depending on their assessment of the benefits, risks and cost, but particularly on cost. It's very important as well to say that in regulation you have 2 areas. There is what was called the Irish Medicines Board, which is now called the Health Products Regulation Authority, the HPRA, and they look at the question of whether a drug is effective and safe to prescribe. It's not their business to decide how much the drug costs or whether it's value for money. They're just simply there to say whether it does what it says in the tin and it's safe to prescribe. And then you have an economic assessment, which is a separate issue, whereby somebody says, well, they're looking for €100,000 a year for this. Is this worth it? Can we afford it? Is it value for money? And that's a different issue to whether the drug is safe or not, or beneficial. And as I say, I don't want to get into the issue, but obviously for a person, it's very hard to put a value on such a thing. And this oral area, and their symbol is the weighing scales, so you can see that what they're trying to do is weigh up things. The other thing that I think is going to happen in the future is, up to now it's generally been between the patient and doctor, as to what treatment is prescribed, provided that is obviously ethical and provided that it's been approved and gone through clinical trials. And, you know, as Gavin said, we used to have a splitting hairs argument about what kind of MS people had, or, you know, do I have relapse remit, do I have slowly progressive, do I have secondary progressive? But it may be that these are all a continuum, and therefore that these arbitrary figures are a little bit difficult to call. And sometimes it can be very difficult as a doctor in the clinic then if you're trying to decide about whether somebody should or should not get a treatment. But I think increasingly what we'll probably have is a web page where your data is put in, and then at the end of that web page, depending on what the algorithm says within the computer, you would probably get or not the treatment. Anybody who's been through the Vampira licensing thing recently, where renal function became a big issue, and whether you got Vampira or not will be aware of that issue. So I think that this is likely to happen in the future, this whole value for money monitoring thing. And I suppose the other area is about stopping therapy. You know, when do you stop treatment? Is there a point beyond which it's not worth keeping going with the treatment, that even as a person that the risks outweigh the benefits, or do you just keep staying on a treatment even though you have continued to progress despite being on it? So these are all very difficult areas to argue sometimes. I'm not really going to go into the complexity of the mechanisms of MS today. We know that the immune system is involved and targets the myelin and the oligodendrocytes and the axons within the nervous system, and that as a result of that, as Gavin so graphically illustrated, we can see both the short, medium and long-term effects. Just to say, a person that both Gavin and I worked with, Professor Ian MacDonald, who passed away in 2006, the reason why his name comes up in your radar is that in 2000, not in 2010, but in 2000, he called together a colloquium to discuss the definitions of MS, so that they would be agreed worldwide as to what MS is, because we're not making a diagnosis based on histology, as you are all aware. It's based on the clinical picture, the MRI findings, CSF, etc., but not actually based on a piece of tissue. And there have been the 2010 revised criteria. The classic aphorism for medical students was episodes separated in time and space. So an episode within the optic nerve on one occasion and in the spinal cord on the next occasion. So different parts of the spaces within the nervous system, and then time that they usually had to be separated by longer than 6 months. What I'm going to do is just give you a few cases then to illustrate as different scenarios. So this is a 20-year-old woman referred from ophthalmology. She's lost vision in her left eye over the last 5 days. The eye is painful on movement. She's a second-year student. She has no risk factors for neurological illness, and she's got diminished vision in her eye, and so on. And the remainder of the examination is entirely normal. So an isolated problem just affecting the optic nerve. And we would call this isolated optic neuritis. Sometimes this person might come to us from the eye clinic. Sometimes they might present to us from the GP directly. So this is what's called a clinically isolated syndrome. And this is the first clinical episode of demyelination, which is usually typically optic neuritis or a brainstem or spinal syndrome. It's defined as lasting longer than 24 hours. And about 85% of people will present with a CIS as their initial symptom of MS. I just put here in small print, some of you may have come across the idea that MS might have been picked up because of an MRI being done for other reasons. So, for example, somebody had a head injury or a car accident, had pain afterwards and went for a scan, and lo and behold, the scan showed MS lesions, which had previously been unsuspected. And that is well described, and that's what's called a radiologically isolated syndrome, RIS, which may, it's not that many, but it's a small number of people. If you think that MS affects at least 1 in 700 people, if you did 1,000 MRI scans, it's likely that at least one of those MRI scans would show MS changes. And the question with the CIS, and to some extent Gavin has been answering that a little bit, the idea of what do we do? Do we say, well, it might never happen again, this is okay, we can just sit back, let's not do anything too radical? Do we have to go forward with treatment straight away? Should the person be going for therapy immediately? And essentially what it boils down to is that we know that if you have optic neuritis, the risk of having more symptoms of MS by 15 years is at least half. And if your initial MRI scan, the scan that's done at baseline, shows some lesions, that's at least 56% at 10 years. Whereas if you have a normal MRI scan, the risk is relatively less. So sometimes if a person just has isolated optic neuritis with nothing else found on the MRI, they might have a debate as to whether this could be just a one-off thing which might not happen again. But even in that scenario, there's still a fairly high risk of having MS within the next 10 years. There are similar issues with spinal problems. if you get a spinal problem as your first symptom, it's likely that you will develop further symptoms of MS in the first 3 to 5 years. So I suppose the question then becomes, if you have a CIS, is that really MS? Really, that it's, that even though it's only happened in the last few days, that in general it does indicate a relatively high chance of going on to develop MS. And certainly, if your MRI is otherwise abnormal, as I'll come to, that certainly would be there. This is just a paper from Brain last year. They looked at 1,058 patients who had a CIS, and they looked at how many people went on to develop further symptoms of MS over 81 months. And essentially what it boiled down to was the MRI. If you had 1 to 3 lesions on MRI, it was a 5 times risk. If it was 4 to 9 lesions, it was an 8.7 times risk. And if you had greater than 10 brain lesions, it was a 16 times risk that you're going to develop MS, further symptoms in the next number of months. The other thing you read about a little bit in the literature, which is a bit of jargon, and I don't want to go into it too much, is called dissemination in space and dissemination in time on MRI. And what dissemination in space means that more than one area of the brain or spinal cord is affected, and the recent revision says that you should have 5 areas. From my own technical side, that's the optic nerve, juxtacortical, periventricular, posterior fossa, and the spinal cord. And you have to have abnormalities in 2 out of the 5 areas to meet the MRI criteria of MS. And then dissemination in time would be that on the same MRI scan, you can see lesions of different age. So you might have one lesion that's enhancing and another lesion that is not enhancing, so that those 2 lesions must be of different ages and different times, so that already on that initial MRI scan, you could already show that the time factor has already been met, even though that MRI has only been done for the first time in that person on that day. And this just gives you some idea of the different locations. This is a lesion here under the cortex. This is a lesion, periventricular lesion. This lesion here in the deep white matter is not actually that specific, interesting for MS, and there's another lesion there. Some other lesions you see, this thing sometimes you come across called Dawson's fingers, which are finger-like projections which come away from the ventricles, and that's sometimes mentioned on scans. And in this particular case, you have lesions in 4 locations, so juxtacortical, periventricular, in the brainstem, cerebellum area, and also in the spinal cord. So that would be 4 out of 4 of the different regions, and as I say, 4 out of 5 of the different regions as well. Again, I don't want to go into this in too much, but so this young woman, let's say she did have that scan which showed the lesions in several different areas. I probably would be, depending on how she felt, I think we would have to have a serious discussion about long-term treatment. And there are several trials that have been done showing that if you start treatment after just one symptom, you can definitely prolong the time to the next relapse. However, the debate is how much effect that has on preventing long-term disability, so that's not entirely clear. Another issue for this young woman would be pregnancy, and I'm going to try to deal with these issues as we go along. Many years ago, there would have been a feeling that pregnancy was bad for women with MS, and one of the reasons for that might be that perhaps if you had a relapse after the baby was born and there is an increased risk at that time, it might stand out in your mind afterwards as a moment in your life where you had this attack and it was in a very vulnerable time, or an important time after the birth of a child. But in general, the feeling at the moment is, based on trials that have been done in pregnant women and also large databases like the MS base, is that at the moment there is no evidence that pregnancy has any effect on MS overall. And in fact, there has been some recent evidence to say that perhaps MS pregnancy is associated with a better outcome, that women who become pregnant might be less likely to have a long-term severe problem. Now, the problem with all of these studies is that a woman who chooses to have a baby with MS may have a more mild form of MS or may have a more benign form, and therefore her decision to have a baby might be dictated by that issue rather than by, and so we may not be comparing everybody who has MS in that situation. The next patient then is a 37-year-old man. He's been diagnosed with MS 4 years ago. He's taken beta interferon for that time. However, this is the second relapse he's had this year with increased weakness of his left leg for 3 days. So the question is, what treatment does he require? So an acute relapse is defined as symptoms with objective signs for longer than 24 hours. And our usual treatment would be pulse steroids. We usually give IV or oral method. There has been some debate about giving oral steroids. Sometimes if we can't get a bed, which is a big problem as everyone knows, or if there's a big family event coming up, or if the person's travelling, they might not wish to come in, they might be quite happy to try a course of oral steroids. And there is some evidence from a trial done in Cardiff a few years ago that there's not that much difference to call between the two. On the other hand, sometimes if a person had a very incapacitating relapse, where they were quite laid up by it, they might have to come in for more support and physiotherapy and other aspects of their care. We do have the possibility of giving day case steroids as well, thanks to the good offices of our very good nurses in CUH, Ethna, Mitten and I, Amani. However, there are side effects with these drugs. They can cause bone problems. There's a thing called avascular necrosis of the hip that can develop if you take too much steroids. You can have psychological effects like mood disorders or even depression or mania sometimes. And sometimes people can get a little bit hooked on the idea of getting steroids, that maybe there's a buzz that comes from getting them that might give you some boost or short-term benefit, which doesn't really necessarily mean it's having a direct effect on the MS. Somebody asked me yesterday when I was giving the same talk, so I apologize for those who were here yesterday, was there any benefit from getting regular steroids? In fact, studies that were done back in the 70s and 80s showed that there was no difference between just getting steroids when you needed them versus getting them as required. So generally, we don't recommend ongoing steroids. There are some units where over the years they've admitted people twice a year for a course of steroids on a kind of a pro rata basis, but generally we don't do that. We just usually give them as required. In this patient, it turned out when he had an MRI that he had a large lesion which actually did enhance with contrast. You can see a faint rim of enhancement. And there's another scan here which shows another enhancing lesion here as well. So basically he had had 2 attacks this year despite being consistent with his beat interferon. And the question is, what should he do now with regard to therapy? So, and Gavin has already mentioned this concept which has come out in the last few years called NIDA. I presume it comes from NADA, perhaps, or some kind of reference to that. But the idea is no evidence of disease activity. So neither on clinical relapses or progression or an MRI, that there's no, over time, that we should try to maintain these things as stably as possible. And that if this is not happening, i.e. if the person is getting more relapses or if there's a build-up in lesions on MRI, then you should not be just sitting back. You should be more aggressive and considering switching up the treatment. And the question is, he's on beat interferon already, so what should we give him? We know that Copaxone is probably somewhat equivalent to beat interferon, so doesn't offer a huge advantage over it. Teriflunomide, in terms of relapse rate, probably somewhat similar to the beat interferon Copaxone. DMF, which is Tecfidera, that reduces relapse rate by 50% compared to placebo. Fingolimod maybe 55%. So do these two represent a significant step up from this one? So possibly. And then the other one would be whether to go for more powerful drugs again, like natalizumab or alemtuzumab, which are the more aggressive treatments according to the ABN guidelines. And of course, as Gavin mentioned, in the next year or so, we're going to hopefully get ocrelizumab, which is looking really promising, although as people know, I've been using some rituximab now off-label for that particular scenario. Daclizumab has just been licensed, and Gavin mentioned sapinimod, which is the other new drug. So in the end, we opted for Tysabri, natalizumab. However, he was JC virus antibody positive, and I'm going to use this then to illustrate another problem which people might have to face. And he developed a speech difficulty, and this wasn't just slurred speech. This was a problem with the content of his speech. He couldn't think of what he wanted to say. He was having difficulty finding the right word. And just to make a point that in PML, which is the illness we're going to talk about now, you have to watch out for cognitive, psychological, or balance issues, particularly, as well as the other type of more normal MS symptoms. Our practice is to scan if there are new symptoms, any kind of new symptoms, as people will know. You can check the JC virus index, which is the level of the antibody, essentially, and that can tell you the degree of risk you have. And some people who are JC virus antibody positive are at relatively low risk if the level is low. And this is work done by Prof. Giovanoni, amongst others. And then generally, you would scan MRI at least twice or 3 times a year to check to make sure that PML is not developing in people who are JC virus positive. This doesn't have to be the full scan that you would do for a standard MS assessment, but it could be a modified version if needed. This is just the JC virus. It's a virus that if we were tested today, about half of us would have antibodies against it, against the virus in this room. It's got nothing to do with MS itself, and it's a mild illness you acquire probably through the respiratory tract when you're a child or a teenager. It can have a reservoir within the kidneys and kind of live on there for the rest of your life. Normally, it doesn't cause you trouble if your immune system is working normally, but if you're on immunosuppression with drugs like the drugs we use in MS, or some of the drugs we use in MS, or if you've got certain illnesses like cancer or sarcoidosis, this virus can start to replicate within the central nervous system and cause this condition called PML. And in this case, on this particular scan, we can see this area of abnormal signal within the part of the brain that's involved in speech. And this is very different to the kind of lesions you would see with MS. Maybe there's a lesion there in this patient who was on it. And so we did a cerebrospinal fluid analysis, and the JC virus PCR, the DNA of the virus was actually detected in the spinal fluid. And so this was PML. Thankfully, the person did quite well when the drug was withdrawn and their condition stabilized. Just to point out as well that to point out what we mean by JC virus, so the JC virus antibodies means that you've been exposed to it in the past. It means that you have evidence that you were exposed to this virus in the past. It doesn't mean you necessarily have an active infection at that moment. It just means that there's a memory in your immune system of having come across this virus before. Whereas when we're using it diagnostically in the spinal fluid, we're actually measuring the DNA of the virus. So you're implying that the virus is replicating somewhere within the nervous system, and the DNA is shedding into the CSF, and you can actually identify parts of the viral particles, if you like. So just to make the distinction between being antibody positive and having the actual acute illness. This is just a picture of the kind of areas of abnormality that show up in the brain on PML, and this is just showing full of viral particles in a patient. So I'm not going to go into that. So a couple of issues for that person who has MS, a relapse remit MS. The third case then is a gentleman from Eastern Europe, living in Ireland for the last 10 years. He has a 2-year history of gradually increasing weakness of his lower limbs, no family history of any similar disorder. On clinical examination, he has a paraparesis. And when we do the MRI scan, he definitely has MS. You can see the lesions around the ventricles. But when contrast is given, they do not enhance. So this is a very quiet process. There's not a huge amount of activity going on in terms of gadolinium enhancement. And the story is of a slowly progressive illness where it's getting worse from the get-go. So this is not going through relapses and remissions. And this probably fits more with the primary progressive story. And the question is, what should we do with him? And thankfully, as Gavin has said, there is some light at the end of the tunnel, because the recent ocrelizumab trial did show that it could reduce the risk of progression in progressive MS by 25%. So that was the first trial to show a benefit. Up to now, the drug therapies have generally been fairly disappointing. Case 4 then, it's a 55-year-old woman who was diagnosed with MS 20 years ago. She was stable and doing quite well up to 2 years ago. However, now reports increasing difficulty walking and using a support stick to go about 200 metres. So her walking speed distance has come down quite a lot. She's had significant urinary problems with 2 recent UTIs, and she's got what's called a high residual. When she goes to the loo, her bladder is not contracting properly, and she's not emptying the bladder, and so that's acting as a reservoir for infection. So what do we do? The options are limited. Some of you may be aware of a drug called mitoxantrone. We would have used this quite a bit a few years ago. It's a very powerful chemotherapy-based drug which was shown to have a benefit in more secondary progressive MS. However, it's associated with significant problems like bone marrow suppression, even a risk of leukemia long-term, and also cardiomyopathy, where it can be toxic to the heart. So we haven't been using it as much these days because we have these other options that have opened up. Gavin mentioned about sapinamide, the recent trial showing a benefit in that scenario. And for her, we're looking at symptom management. So 2 drugs particularly, fampridine, which is the Vampira that some people may be aware of in the audience. This was a drug which is supposed to boost nerve transmission, so it's supposed to make the nerves more efficient, if you like. It doesn't have any direct effect on MS itself, so it's not treating the immune system. And I suppose what it does have is the advantage that it's trying to help you in the moment rather than something that you're taking for some long-term gain. What happened was the trial that they did, if I remember correctly, they said that 40% of people who took it had a greater than 25% improvement in their walking speed. So by taking this drug, you could improve your walking speed by 25%, but in less than half the people. So it was not a particularly stunning trial in that way. However, the drug has been given a license worldwide. Those who are aware in the audience who've been trying to get it realize that initially Biogen made it available for free as a pro bono thing, pending sorting out with the government. That didn't happen. Then some people were paying for it for a while, and then more recently there's been a HSE system for getting it through the drug management system. However, as people know again, Vampira is excreted through the kidney, and if you have impaired renal function, whereby the kidney is not getting rid of the, not processing as quickly as usual, this drug can build up in the system. And I suppose the biggest side effect, which I've never seen, is seizures being triggered by Vampira, so that it might trigger epileptic seizures in some people. And because this could be linked to a build-up in toxicity when people had renal impairment, for that reason, the HSE system would not accept a GFR below 80 mils per minute. GFR is glomerular filtration rate. It's a measure of the activity of the kidneys, so that can be an issue for some people. My own experience is that some people do find it very good, and others have said it didn't really help very much. So I wouldn't say it was universally successful, but some people have found it helpful, at least symptomatically. The other one is cannabinoids. We know that there's a drug called Sativex, which has, if you actually go to the HPRA website, is licensed in Ireland, so you can actually get Sativex if it was available. So it's not that it's illegal or anything, it's actually on the HPRA website. If you go to the hpra.ie website and Google Sativex, it's there. However, the company Almirall have not sold it in Ireland yet, so it's not commercially available in this country. At the ECTRIMS meeting last week, I saw the Almirall stand was there. It's quite a big stand, but it has not been released, and it may help with lowering things like muscle spasm or pain, and some people again find it quite helpful. And then the other area, just to emphasize the idea of, which I wanted to point out here, is the idea of management by a group of people. So we get enormous help from our colleagues in urology or our nurse advisors. And in this particular case, because we don't have great drugs to empty the bladder when it's not contracting, she opted for intermittent self-catheterization and found that very useful for helping her care. One area that Gavin mentioned briefly whilst in his talk is the idea of stem cell transplant or hematopoietic stem cell transplant, or HSCT. Now this has been going on for a while. It's not today or yesterday that this has gone on, and it's actually been looked at in other autoimmune diseases as well. So it's not just in MS that it's been looked at. And I suppose the idea is that your immune system has a memory. If you think of our brain having a memory, and our mind having a memory, the immune system also has a memory, and that's why when you get chickenpox as a child, you can still detect antibodies against that virus 40 years later, and 98% of us in this audience will have antibodies against chickenpox, for example. And that lives on as a memory within your immune system and protects you from that virus again, mostly, although we know that you can get things like shingles. So the idea then is that if there is our cells circulating within the immune system that are activated against the brain or the spinal cord, that perhaps if we could reboot that memory, if we could eliminate those cells from the bone marrow or that clone of cells, then we could reboot the immune system and we could start again, and maybe therefore not have to worry long term that this ongoing inflammation is going to keep happening within my nervous system with all the consequences that Gavin so graphically said earlier. In the big paper that had a lot of traction lately from Canada, it's a 3-stage procedure. So you come in, you get a stimulation of the bone marrow to produce some stem cells. So they're taken from the patient themselves. They're not from someone else. They're actually your own cells. Those cells were harvested. You then go through a form of chemotherapy called immunoablation, where you receive extremely toxic drugs to wipe out your own bone marrow or your own immune system. And then after a few days, you transplant in the cells that you've harvested previously, and hopefully they go into the bone marrow and regenerate the immune system again, and you start afresh with new cells. These are not stem cells within the brain. It's not to do with nerve grafts or treating the nerve injury or trying to regenerate the neurons or the myelin. This has got to do with going into the brain itself, or going into the bone marrow. One thing that you've got to be aware of, that in the trial, in the Canadian study that was published, there were 24 patients, so a very small number, and one of the patients died as a result of liver toxicity from the treatment. So that was a 1 in 24 mortality. 2 of the people had gone on to go for an alternative treatment called CCSVI, where they'd gone for some stenting of the veins in the neck, again, a controversial thing which I would not recommend, and they were excluded from the study. So only 21 patients were analysed in the end. All of them had had active MS and had moderate to severe disability. All of them had been tried on multiple drugs beforehand and had failed treatment, so they were the criteria that were used, and I think they were all between aged 20 and 50 or 15 and 50, so they were all relatively young. And what they said in the outcome in essence was 30% of people continue to disimprove, so they didn't get a benefit. They actually continued to disimprove for a couple of years. 30% of people stabilized, and then about 40% of people seem to improve somewhat, including some who seem to improve quite a lot, rather like the cases that Gavin illustrated, where he showed patients who had individually excellent outcomes from other treatments like alemtuzumab. So you can take that and look at it and say, obviously, if you've tried multiple treatments and you're keen to try anything to treat your MS, that you might consider it. I've had I suppose the reactions in the clinic can probably be put down to twofold. Some people, as you start talking about the treatment, their eyes widen and you can see that they're quite scared and concerned about the possible risks and side effects of the treatment, whereas other people might be more keen to try something and would be keen to give it a risk. I suppose it has that appeal of the one-off thing that you run the gauntlet for a month or whatever when you're going to treatment, and then hopefully, if it's successful, you might have beaten it, and therefore you don't have to engage in long-term therapy or long-term treatment. So you can see how that might be appealing. But again, I would counsel great caution, and at the moment it's not commercially available, so it's not something you can just opt and say, I'd like to go and have a HSCT, please. It's all being done in trial centres, and not everyone is suitable. There are places around the world where you can go and pay, and some people, one of my patients said to me, up to 150,000 euros. But I would counsel people to be extremely careful. This is a treatment which could have mortality. It's not just a treatment which might do you no harm kind of thing. But I would counsel people to be extremely careful and, before engaging in something like this. This is just a paper which was published in The Lancet, and I think there was a programme on BBC a few months ago from the Sheffield group. I'm not really going to talk about the last case very much because it's more from a neurologist's point of view, but just to point out that not everybody who has what everyone thinks is MS really does have MS, and there are a whole list of conditions which can mimic MS. So we always have to be very cautious that when we give a diagnosis that it's as correct as it can be, given that limitation that we don't have histology in the main. This is a condition called de Vick's disease. Lastly, I just want to say about a team approach. I could thank so many people on our team, our fantastic nurses, the physios, the OTs, the nurse specialists, psychology, psychiatry, everybody who tries to help in helping people with MS to have the best outcome that they can have. I'd like to particularly thank Carmel Collin, who, as we all know, in the South, has done such tremendous work and has helped to organise many meetings like this over the years. So I know she's retiring, and I would like to recommend that we have a round of applause for Carmel. And I think she's planning to stay on in some capacity, so I don't think she'll be completely disappearing. So that's all I want to say. Thanks.
Hi, Dr. Sweeney. We have a question from Twitter.
Yes.
Marie O'Connor would like to know, how important is diet in reducing inflammation?
I think it's a difficult question. As I'm sure anybody who has MS, if they go online, you'll have various diets being promoted. Cut out gluten or cut out various components of your diet. I would be sceptical about most of those, I'll be honest. Again, I think if you have a healthy, balanced diet, the debate about vitamin D supplementation goes on, and again, MS is more common in temperate climates, so perhaps vitamin D supplementation is important. But I think apart from a good healthy diet and avoiding the things like hypertension and diabetes and trying to keep your weight down and so on, as Gavin has said, I wouldn't want to give a more specific recommendation than that. There is the debate about the Mediterranean diet, about things like olives and all of those kind of Mediterranean things for long life and all that, but I wouldn't be prepared to give a specific recommendation.
Sorry, Dr. McSweeney. Just like to ask you, would you recommend getting the vaccine against shingles? I already got shingles this year very badly, and I'm on alemtuzumab, and I'm just wondering, should I prevent
Have you had your antibodies checked? Do you have antibodies against the varicella virus, do you know?
No, I don't know.
Yeah, so just to deal with that, varicella is, zoster is chickenpox, so it's chickenpox in childhood, and because it's so highly infectious, there isn't a vaccination program in Ireland. Now, as we all know, anybody who has kids knows that chickenpox can be a nasty illness. It's not a benign condition. I think in the States they vaccinate against chickenpox, and I think there's some debate about whether, I'm not sure if it's even come in here. 98% of us will have antibodies against the chickenpox virus if we were tested again in the room, and we've only had a small number of people who, one of the conditions of going on fingolimod has been to be immune against chickenpox if possible, because there have been a couple of cases of chickenpox in association with that thing. In terms of whether it would be worth your while boosting your immunity by getting the chickenpox vaccine, maybe it would be if you've had the chickenpox already. But you can actually have your antibody level checked to see if you're at, the way you can have German measles antibodies and so on checked. You can have them checked and see if you're positive.
Okay, thank you.
Hi, my neurologist has stopped using contrast enhancements when doing my yearly MRI. Is this a step backwards, seeing as I have Tysabri?
Okay, so there is the substance that we use in MRI is called gadolinium, and it's a paramagnetic substance. MRI, as you know, is a powerful magnet. That's what it does, the magnetic field. And generally, there are some complications. So, for example, you'll know that if you have impaired renal function, there can be problems with getting gadolinium, and they usually ask your creatinine and all that before you have a scan. And there has been some concern lately that gadolinium may be found in the brain of patients who've had MRIs in the past, so that if you do studies of people who've had a number of MRI scans with gadolinium, that the gadolinium can hang around a little bit and that it doesn't just disappear from the brain. And so it may be that we should be a little bit judicious about that. Now, the FDA has not given any particular advisory to people to say that there's harm from this, but they have put it on a watch list so that they want to see if there are any harms that might come to people from having too much gadolinium. So there is a theoretical thing there. Now, there are other parameters of the MRI that can tell you whether you have active lesions or not. It's been used very much as in trials because the number of gadolinium-enhancing lesions has been being reduced, has been shown to be a benefit of the treatments. So I think there may be a good idea of not overusing it, and hopefully with the comparison with the previous scans, they'll be able to just make sure that your lesion load is staying the same, and that and then maybe if there's an individual flare-up or whatever out of time or out of the normal order, maybe then they could do a scan with GAD if they wanted. But it does add a little bit more information, but there have been some concerns about, there are some possible concerns emerging about it long term.
Good morning, Doctor. As MS treatment suppress the immune system, would you recommend that we should be taking probiotics to strengthen the bacteria in our gut?
So that's an interesting question. We've been trying to do a study. One of the areas that has been looked at in terms of how does MS get triggered has been the GI tract. It's obviously an open pathway to the outside world, and we have this gut microbiome. There's a huge unit in UCC that does a lot of research on that area, and it's a big issue worldwide. And there have been some papers. There's been a recent paper from Harvard where they said that there were certain differences within the bacterial flora in patients with MS compared to controlled subjects. And we've been trying to do a study ourselves in the last couple of years on this, and we're hoping to, it's coming to fruition at the moment. I can't comment to you as to, there is a big industry out there selling probiotics. It's a big growth industry, and in fact, again, UCC have floated off on the stock exchange recently on a microbiome, a gut-altering bacteria case. Sadly, I don't have any of the shares, so I think it's kind of interesting, but I can't say to you for sure that it's definitely going to make a difference. But I don't think it would do any harm, certainly. But I can't give you evidence at the moment to say that that's a good idea. Yes. One more question.
Dr. Sweeney, just about lumbar puncture. I see that Dr. Giovanni was talking about in the course of diagnosis that we're going back to using lumbar puncture to diagnose MS as opposed to or in conjunction with MRI scanning. Yes.
So you just asked me to comment on that.
Yes.
So generally, in the past, as you know, I don't know, back in the past, before MRI became available in the mid-80s, the CSF analysis was quite important. And also, it would, as I remember as a junior doctor, it would often be combined with a myelogram, because in case somebody came with a spinal problem, you'd run some dye up along to make sure there was no disc pressing on the spine to cause the weakness as a differential diagnosis. And I suppose one of the things about CSF is at least it's fluid that comes from within the nervous system. It's one of the closest we can get, given that we don't go directly in and put a needle into the brain itself or spinal cord because of the risks. So, and what Gavin Giovanni is saying is that there's some emerging stuff now that you can measure other proteins within the spinal fluid, which might give you some prognostic information and might also be used as a way of monitoring treatment. And then lastly would be for the JC virus, if you're looking for the DNA of the virus, if somebody was suspected as having PML. So I tend to do it still. I don't think it's an absolute. But because I try to make sure that we've covered all the bases and that all of the boxes have been ticked, I usually still do it. But you don't absolutely have to have it done. And MRI is still the most, I think it would be 98, 99%, whereas the CSF would be about 95%. So, as you say, the corollary of that is that you could have about 1 in 20 people, some people say 1 in 10, could have MS and have a normal lumbar puncture. So it may not always help there either. Yeah, but so it does live on. It may not be completely eliminated yet, sadly.
Hello, Dr. Sweeney.